And this is the crucial thing. We don't know what we don't know. AMIs, do you think it's reasonable for us to miss? I mean, who wants to miss, put your hands up, less than 10%? I hope you'd all want to miss less than 10%. Okay. Keep your hands up if you want to miss less than 5%. I want to show hands. Who wants to miss less than 5? Less than 2? Less than 1? Less than, you should all have your hands up, but that's all right, this is reality though. Less than 0.5%. Okay, so the people that got their hands up at 0.5 and at 1% are going to be sorely disappointed because we tend to miss about 2%. The symptoms, how good are we at predicting the value of symptoms and signs in the emergent diagnosis of acute coronary syndrome? This is a prospective study in the European Resuscitation Journal. Had nearly 800 patients in, and they looked at the validity of common symptoms and signs. So let me ask you a question. Who here thinks that crushing central chest pain is the most important symptom that people will, for us to judge whether it's cardiac or not? Hands up who thinks that crushing retrosternal chest pain. Okay. Who thinks that shortness of breath is the most important symptom? Who thinks that pain down your right arm is the most important symptom? One person, well done. Who thinks that pain down your left arm is the most important symptom? So there's a few of you that have to put your hands up. So if I were going to give you a constellation of signs and I said to you, central chest pain and pain down the left arm, is that more important than right arm pain and shortness of breath? Who thinks the first one is more important? Okay. This is an important fact because we've been taught central crushing, chest pain going down the left arm into the jaw, diaphoresis, shortness of breath. These are kind of really important signs, okay? And they are. There's a few other things that have emerged that are more predictive. So, right arm pain and both arm pain has a higher odds ratio than left arm pain. Right arm pain is worse than left arm pain if they present with that. Vomiting. Diaphoresis is one of the most important signs in potential cardiac disease. And central chest pain, of course, scores highly. So if somebody comes in with central chest pain, diaphoresis, and they also have some shortness of breath, that's a slam dunk. Okay, you've got to chase that. If they come in with, bilateral arm pain, if they're old, I miss so much stuff in the elderly. We all do. Okay, because they're wired a little bit differently. They get different pain. They get visceral type pain. They may present with abdominal pain and it's cardiac. It's really strange. They may present with no pain. They're there to make your life difficult. So you've got to start thinking about stuff. All right. So this was a registry-based study looking at patients greater than 75 years of age. They had 12,000 patients in this study. Now, not statistically significant their results, but showed a good trend. That in fact, the elderly that presented with typical chest pain, it wasn't cardiac. The ones that presented with a more atypical pain were the ones you had to worry about. 50% of patients with no chest pain had dyspnea. A quarter of them had diaphoresis, a significant number had nausea and vomiting, and some of those patients presented with syncope. 25 to 50% of patients with an AMI have an initial normal ECG. So you need serials, you need serial blood, serial ECGs. And this is kind of the important part of this. If there are no ECG changes, there are still significant risks. So an ECG is not perfect. You've got to put the whole constellation together. How about the GTN challenge? I gave them a little bit of anginine and they got better. Must be cardiac. Bold to that, right? It can be esophageal spasm, but you can't ignore it once it happens. So either don't do it or do something about it if it happens. How about the pink lady? Give them my Lantern xylocaine cocktail and it goes away and it's gastric. Can't be anything else. How many people have I killed with that in my younger years? Absolutely. But about 15% of patients with AMI get some relief. 7% of patients with AMI get total relief from the pink lady. Give me some of that, right? Total relief doesn't mean accuse their AMI. Now, reflux. This is the most common misdiagnosis. Medico-legally, this is the most common suable thing out there. People say, you know, patient comes in, I get these all the time. Oh, I've got this pain, doc, but I feel like belching, and when I belch, it's a bit better. I'll get a bit of, you know, reflux. Can't be anything else. The problem is that there is a higher incidence of gastroesophageal reflux disease in these patients with coronary artery disease. Okay, they're already a higher risk group for us. About 8% of AMIs will begin while these patients are eating. About 20% of cases of AMI I'll describe as indigestion, and half of them will feel like belching. Be careful with the gastric symptoms. Is there a lower risk group? There was a great little study done in the academic emergency medicine that looked at a younger risk group for excluded patients that had no cardiac history, normal ECG, and no cocaine use, because cocaine is an independent, and we'll talk about cocaine another time. But there was a group here that said if they'd had no cocaine use, no previous cardiac history, normal ECG, negative first set of enzymes, and they were young as well, in a younger risk group, chance of acute coronary syndrome was significantly low. So that is one group that we can look at sending home.